If you are pregnant or planning to be, you've probably heard alarming headlines lately about Tylenol, SSRIs, the risk of autism or ADHD. It's enough to make anybody anxious, even without a history of mental illness. So today we're cutting through all the confusion and the fear. I am joined by psychiatrist Dr. Katie Unwerfer, a board-certified psychiatrist who specializes in perinatal mental health, to discuss what we need to know and how you can make empowered, informed decisions for your mental health and your baby's well-being. So thank you so much for being here again.
Yeah, thanks for having me.
So happy you're here. Truly, this has been something that I look at and I listen to the news and I kind of start to look cross-eyed. And so I need somebody who knows a lot more than I do.
Yeah, happy to help.
Okay. So let's get straight to it because I want to sort of get to the point as fast as we can to help people manage this or at least be informed enough to make their own decisions. So
Mhm.
let's talk about the recent headlines around Tylenol. What is happening there? What is the FDA responding to with these sort of new labeling discussions?
Yeah, so I think what the FDA is responding to is that there have been some recent studies that have associated Tylenol with an increased risk of autism in pregnancy. So the FDA recently sent like an article or a letter to physicians, sort of advising them that there are some studies that show that there's an association of Tylenol with autism in pregnancy, but it does say in that letter that it's not a causal link, that a causal link has not been established. I think that when we look at this data a little bit deeper, there are studies that show an association, but what complicates this is that we know that Tylenol use in pregnancy is often used for fever. It can be used for infection. It can be used for pain conditions, and it can be used for migraine. Those conditions have each been associated with negative neurodevelopmental outcomes like ADHD and autism. And so, not while some studies might show an association, in my read of the data, it looks like it might be actually the conditions themselves that increase the risk rather than the Tylenol use. Um, there are a few studies that specifically look at this. So when we have these issues in the field of like perinatal medicine, what we try to do sometimes is we try to separate out, kind of these environmental genetic risks versus the medication risk. One way of doing this is something called sibling controlled studies. So what you do is you look at the same mom, two different pregnancies, and you compare the exposure in each of the pregnancies. So it's sibling analyses. And so they actually have done two very large studies like that with Tylenol. So same mom, and she used more Tylenol in one pregnancy and maybe no Tylenol in another pregnancy. And what they found is in those studies, there was no increased risk of negative neurodevelopmental outcomes like autism or ADHD with Tylenol use. What that tells me is that Tylenol use is more of a marker for an increased risk for autism, but that it's not actually causing that increased risk of autism. It's much more likely to be related to genetic risk factors for autism, familial risk factors for autism, environmental risk factors for autism, but not really the medication itself.
Right. That's super helpful to know. One question, and this may also be my lack of knowledge, is why was it called Tylenol and why was it all over the news, the word Tylenol, and not the actual name of the medication? Like in Australia, I think there's two ways you can say acetaminophen and we would say acetaminophen.
Oh,
So
that's good to know.
and I was surprised. So is there a reason why it was labeled Tylenol only?
Mm.
Why was it not called the more or is that just because it's easier to say?
I think it's because it's easier to say. I think it's because in the US, people use them interchangeably. So it's Tylenol or acetaminophen.
Okay.
I've seen in some of the studies they call it paracetamol. So I don't think it's specific. We have the brand name Tylenol.
Okay.
I think it's just people switching back and forth between generic and brand.
I understand. I was like, wait, is there something specific about that brand? Like, oh, wait, is there something I also didn't know? That's a great question. A great question. Yeah. So you've already sort of helped us to understand this. Now, we're here talking about a mom who is pregnant and just wants to have a healthy baby. And in today's age, there's so much on the market and pushing and pressure to eat well and breastfeed your baby. And you've got to kind of jump through hoops. And it does feel like a lot of pressure that it's our job to prevent these scary things from happening to our children. So, in this case, let's say someone was coming to listen to this and they were more like, oh my God, I did take Tylenol, but now I'm understanding it's not that. It's more the fact that I had a fever or I had or migraines. How might someone manage that as a pregnant woman, manage the anxiety of that, do you think?
Yeah, I think that's a great question. I think speaking with your provider, speaking with your OB-GYN, I think is always helpful. I think that everybody's doing the best they can to manage these things, right? I understand that there can be a lot of anxiety worrying about exposures. I think specifically with Tylenol, I think that this isn't necessarily a fear that's based in reality, right? But I do see and have seen in my practice how, if we're saying that something that's generally been considered so safe in pregnancy isn't safe anymore, it can make people so worried about all of the other things they did during pregnancy, right? So it just really can increase worry when people are already so worried, right? I think what's really helpful is to, stick to really reputable resources to get information. So I think OB-GYNs are really helpful. Perinatal psychiatrists can be really helpful. Family physicians can be really helpful. I think getting support from friends and family is helpful. But I do think that this is an anxious time. This is a difficult time to be pregnant because there are so many like mixed messages in the media right now. There are so many mixed messages, coming from like the administration as well. And so I think, finding an OB-GYN that you trust and really relying on them to help you navigate it is important.
Yeah, thank you. I think back too is I've had two children,
Hmm.
and I took Tylenol for both.
Too.
A and
So.
and I had a fever in my daughter, as I remember, but I don't think with my son. I had a series of, like, really bad, like, stomach flus and viruses, and it was just, like, a crappy year. It actually, like, wiped out our whole Christmas, like, everything of Christmas got ruined. And I'm hearing a lot of people online even saying, I have one child with autism and one not, and I didn't have a fever or anything in that pregnancy. And so I think, particularly for us anxious folks, we're all like trying to calculate this, like one fever check, and you know what I'm saying. So now, what do we know? Like, are we starting to figure out the cause of autism and ADHD? Is this about us now understanding more about the actual reason we have it, or are we still a long way away?
I think it's very complicated, unfortunately. I think that what we do know is that what they're starting to look at is like polygenic risk scores. So it's looking at sort of a variety of genes that interact to lead to the increased risk of like autism or ADHD. I think when I said that, migraines are associated, what it seems like is that migraines are sort of associated with this genetic risk factor for autism and ADHD, not necessarily that migraines cause autism or ADHD. I think a lot of these things are associations.
What I was asking really is, are we getting closer to understanding the cause?
What I do think will be good is that this administration is really shining a light on autism, and it sounds like they're about to dedicate a lot more resources to really trying to figure out what the underlying causes of autism. What we know best at this point is that it does seem to be both genetic risk factors, so meaning genes that sort of cluster within families that increases the risk for autism. And then it seems like there are some environmental risk factors, meaning like toxins, meaning pollutants, but also environmental risk factor could be like certain infections. But is there a clear, specific cause of autism yet? I don't think we know. And more research is needed. So I do think that will be good.
Right. And so, what advice would you give pregnant mom or families who, have, expecting?
Yeah.
What advice might you give them besides speaking to their doctor, of navigating the anxiety of this sort of news and the way the media is handling it?
Yeah, that's a great question. I think therapy has a lot of evidence in this situation too, right? Because obviously having some anxiety around this is understandable. But what I always say is when it takes on a life of its own, that's really when we know you need to seek treatment, right? So it's okay to having some anxiety about Tylenol use right now is understandable. If it then generalizes to every single decision you made in pregnancy or every decision you're going to make moving forward, at that point, I really want you to work with a therapist to sort of help weigh, these different intrusive thoughts you might be having. So in pregnancy, we know that cognitive behavioral therapy has a lot of evidence for treating anxiety and depression. Interpersonal therapy, IDT, has a lot of evidence for treating anxiety and depression. I think really focusing on mindfulness. I tell all of my pregnant women, I really want you to work on being flexible, right? Let's be flexible during pregnancy, because the pregnancy experience is really different for everybody. And one of the best things you can do is sort of be present with whatever happens and however you feel. There's some evidence. I mean, now we're just kind of talking about more like treatments for anxiety and depression, but massage has some evidence. So sometimes if people have resources or are able to, getting intermittent prenatal massages can be helpful. Acupuncture has some evidence. Exercise can be helpful. These are all just sort of evidence-based things to manage anxiety in pregnancy. But I think part of it is just understanding that there is going to be anxiety around decision making in pregnancy because there have been these messages recently that like you might have done something wrong. And so understanding that, being present with that, accepting that, but then if it really does start to take on a life of its own, seeking care from someone who specializes in that.
Yeah, absolutely. I remember, like, having anxiety about which car seat I bought. I mean, it was
Yeah.
like
Or strollers. There's so many strollers.
yeah. Yeah, but feeling like, "But, should I buy the $600 one? Because what if we got in an accident?" And you start to calculate, like, it's a whole thing. What I think is interesting too, and I'm noticing an increase in my own practice, is sort of this general we have health anxiety, folks who have
Mhm.
hypochondria worrying about themselves, and sort of now this, like, health anxiety by proxy, like, their health anxiety is around the child, what could impact the child, and I think that it's so hard. The messaging is so scary, and it's everywhere on social media. So I'm sure for a lot of folks, that sort of health anxiety has really, increased. Okay, so I feel good about that. Let's shift because there's two main topics I wanted to discuss today. So the next one is the FDA expert panel has revisited the safety of SSRIs in pregnancy.
Mm.
Can you tell me I didn't even know about this until you had reached out to me and said, "Let's talk about this news." And so I was a little bit like, "Oh, I missed this. How did I miss this?" So do you wanna share with me a little about what's going on there?
Yeah, so the FDA panel was revisiting SSRIs in pregnancy and relooking at their safety in pregnancy. It was a panel of different people who regularly prescribe antidepressants, but there was one person who was a reproductive psychiatrist who really focused on using these medications in pregnancy and postpartum. So what they were doing is they were sort of relooking at a body of data. Unfortunately, it did seem like in kind of a similar way to the Tylenol studies, that they were looking at a lot of studies that showed increased risks with SSRI use. But it is a very similar story to Tylenol in that way, in that the studies that show increased risk with SSRI use are really failing to take into account both the increased risk of just being depressed in pregnancy and also familial, genetic, environmental factors that increase the risk for negative outcomes rather than the antidepressant itself.
Okay, let me unpack that.
Yeah.
So I think what you're saying, but please tell me if I'm wrong, is you're saying the prevalence of having depression or anxiety, which is why you're going to get that prescription,
Right.
could be more the core, like there's now we're showing there's genetics, it's showing up that the child is more likely to have some sort of mental health because of that.
No. So what I'm saying is that it's called confounding by indication. So it means that the indication for which the medication is used causes the negative outcome. So with SSRIs, what we know is that depression in pregnancy has negative outcomes, both for the mom themselves in terms of just, the burden of being depressed,
Yes.
but for also the pregnancy and the development developing infant. And so with the pregnancy, it leads to preterm birth, low birth weight, preeclampsia, increased risk of emergent C-section. Also with the developing fetus, it can lead to low birth weight, which I already said. Also, it can lead to negative neurodevelopmental outcomes, actually. So there are some evidence that there are behavioral issues with children who are exposed to depression in pregnancy, some changes in immune regulation, some changes in stress response. And so what we know is that depression in pregnancy isn't benign. It leads to negative outcomes. It does not seem like adding an SSRI increases that risk further. And so I think what can happen is you can find studies that will say SSRIs increase the risk, but often they're not very well designed studies and they're not controlling for the depression itself.
So let me understand this, and thank you for clarifying that because I think I was saying the same thing, but I didn't articulate it very well. But
Sorry if I
no,
misunderstood.
it's I'm trying to make sense of this in my head, but I'm not a research, I'm not a researcher.
Sure.
But wouldn't that then mean that we want them to go on SSRIs because we want to reduce the depression and the anxiety? Like, my fear is someone might see that the SSRIs are these sort of like they've associated it and that's not good. So then I shouldn't go on it. But isn't it what you're saying? And maybe I've got this wrong. Like, we actually need to manage that anxiety and depression for those beneficial outcomes.
Yeah, I think what I will typically say is that stability predicts stability, right? So one of the best things we can do is kind of protect mom's mental health the whole time. And that really begins before pregnancy, right? So the best thing we can do having you go into pregnancy is feel mentally well and stable. That predicts that you'll continue to feel that way during pregnancy, and that predicts that you'll continue to feel that way in the postpartum. So certainly untreated depression and anxiety have negative outcomes, right? What I will tell people and what people really resonate with, especially if they've had sort of severe depression or anxiety before, it's an inflammatory state, right? You feel off. Your heart is racing. You're having all of these intrusive thoughts. It's hard to function. It's especially hard to like go to your therapist sometimes. It's hard to make your appointments. It can be hard to like eat healthy, to exercise, to engage with friends and family, right? So treating that with an antidepressant can really have all of these benefits, separate from just treating the depression. It can really improve some of the behaviors that we know are positive for a pregnancy. What we also know is that untreated depression in pregnancy is the biggest risk factor for postpartum depression. So sometimes I'll see people in pregnancy who are depressed, clinically significant depression or anxiety, and they don't really want to take an antidepressant, which I understand, right? But then they're so worried about postpartum depression. They're like, but I'll feel better in the postpartum, won't I? And unfortunately, that doesn't seem to be true. Even though some people think they will, most studies kind of show that there's a continuation of the depression and maybe a worsening in the postpartum.
Yeah.
So really, I encourage people to sort of let's treat their depression or anxiety to remission, right? We really want to have them feeling well and healthy.
Yeah. And as a clinician, I mean, I'm not swaying listeners who are listening either way. I can't tell you how many times I'm have clients who are in the middle of pregnancy and they are muscling through, trying so hard to use the skills and practice the tools and doing their homework so that they don't have to go on medicine. And with some benefit too, as you said, CBT, exposure and response prevention, are very highly successful treatments, especially for OCD, if we're talking about exposure and response prevention. But hormonally and environmentally, they're struggling. And then when they do go on an SSRI or they sort of, hit rock bottom, they're like, I wished I had have started earlier. There was such a stigma to medication, which I fear is going to be even worse now. And have just said that helped me to cross the finish line and it was so helpful. And so I sort of just wanted to share that for folks is I see it all the time, but
Mhm.
there's a lot of pressure on mums to give up their own mental health for the wellness of their baby, and that's what worries me.
Right, it starts in pregnancy, that really intense pressure. I think that makes a lot of sense, right? What we do talk about, and to kind of help people weigh this a little bit more, is that we do talk about sort of this risk analysis, right? So we both talk about sort of the risk of untreated depression and anxiety, or even partially treated depression and anxiety, right? Someone who's sort of muscling through and maybe getting getting like 30 or 40% better, maybe 50% better, but still having clinically significant depression and anxiety. So we talk about the risk of that versus the risk of a medication, right? So we want to weigh those two things. What I see sometimes in my practice, sort of is similar to what you see, is that I'll see people who are really trying to stay on the lowest dose of antidepressant they can, but are still having a lot of depression and anxiety. In that setting, we would prefer to increase the antidepressant and decrease the symptoms, because in that way we think about it as one exposure. So we would rather have them not exposed to the depression and anxiety and just have them on the antidepressant. And so that's sometimes how I help people think about it, to really encourage them to treat their symptoms instead of, kind of, I agree, there's this self-sacrificial, understandable mentality, but I actually think in pregnancy, it's a little bit misguided. We really want you to feel the best, and we know that that's the best for your pregnancy.
Right. And would it be true too that you would speak with your doctor about your genetic risks? Like, is it also like, I think about me with, let's say, breast cancer. So I have breast cancer in my family. If you make a decision on whether to go on hormone replacement therapy or something, they're asking you all of these risk factors. Like,
Yeah.
is there a history of breast cancer? And that helps them to determine the prescription. Is it
Yeah.
like that with this as well? Or is it more dependent on, like you said, the one risk, I think you said it was called, or the one.
Oh, the polygenic risk.
Yeah.
Yeah. No, so mostly with this, what we're looking at is we're looking at symptoms. Just so, yeah. So I think in psychiatry, we almost exclusively look at symptoms and treat symptoms. Hopefully in the next 10 years, 20 years, we'll be able to more specifically say, like, oh, your cluster of genes means this, which means we should use this medication, which means this is your risk and this is how you decrease it. Like this field at like precision medicine. I hope we get there, but we're not there right now. So really what we do think about is, I guess it depends on what we're talking about. Because if we are talking about risk for depression in pregnancy, that there are certainly very specific risk factors for. But really thinking about like genetic risk, not necessarily. If you had a family member, like if your mom or sister had like severe depression in pregnancy, you're at risk for that. If they had postpartum depression, you're at increased risk for that. If you have a history of premenstrual dysphoric disorder, so like depression, anxiety, irritability, mood instability in the luteal phase, right? That's PMDD. That increases your risk for depression in pregnancy and postpartum. If you have depression related to hormonal contraceptives, that increases your risk for depression in the postpartum. What we sort of look for is a history of hormonal sensitivity, right? So we know that some people have abnormal mood responses or have very intense mood responses to changing levels of hormones, and that increases the risk for depression in pregnancy and postpartum.
Okay. This has been so helpful because I feel like you've just given us a very level, a good understanding, a good education of what it is and all of these things. So, okay, when it comes down to it, it's almost like having more information is so helpful, but also scary.
Yeah.
Right? Which, it's sort of the same with when you have the what is it when you get the big needle?
Amniocentesis.
Yeah, it's like, it's so great that we have this, but it's also so anxiety that provoking that you've got to go have this test and get these results. So what advice would you give generally to a mom who is overwhelmed? Would you encourage her not to be watching the news, or would you encourage her to be watching the news? Would you be encouraging her to get one or two doctors' opinions? Like, to what degree should they be proactive versus also protecting themselves from all of this?
Yeah, that's a great question. It's a really difficult time. I think, right, it's like I am an academic and I do research. And so I know about sibling control analysis, and I understand, how that matters and how that changes sort of the landscape of data. But no, we can't really expect everybody to know that. I do think the data, like what I would rely on are like medical society guidelines. So, for example, the American College of OB-GYN, ACOG, has said that they feel very comfortable continuing to use acetaminophen in pregnancy, right? The Society for Maternal Fetal Medicine has also issued a similar statement. I do think that there's a bit of a disconnect from the messaging we're seeing in the media at this time, and also the messaging we're seeing from physician organizations. As a physician myself, I tend to follow what physician organization recommendations are making, just because I trust that they have sort of the top experts in the country making those recommendations. And historically, those have really been in line with how I understand the research, how, the majority of physicians understand the research. So I think that those are some good places to get information. I think, choose your sources wisely. There is an online influencer who will say anything, and you can find really the range of different people. And so I think it's tough, right? We're all a little bit in our information silos, and so trying to seek different opinions, trying to find sources you trust, trying to find physicians that you trust is really important. But yes, it is. There's no perfect way of doing it right now. And it is a difficult time. It's a
Yeah.
really difficult time.
Amazing. Thank you. I'm so grateful for this. Really, I am. Because I mean, even as I'm thinking back, it is so confusing. It is so scary. But I think I think what you're saying is go to your doctor, get very specific advice from them on what they think is best for you in your specific situation. And that it doesn't mean you have to muscle through a fever on your own with no assistance, because that's not helpful for anybody. So I'm really grateful. One question just to clarify as well is the boards, you listed a couple of boards. Are they also saying the same for the SSRIs? What are they suggesting?
They are. They are. Yeah, the similar for SSRIs, it is across the board recommended to treat depression in pregnancy. And SSRIs at this point have decades of safety data to really support their use. Yeah.
Thank you. And I think there are specific medications for pregnancy that they recommend. We've done an episode on that once before, which I'll link in the show notes. But do you want to sort of share what those are? Those pregnancy.
Yeah, of course. And so it really depends on in pregnancy if this is a recurrent episode of depression for you or if this is sort of a first episode. So if it's recurrent and you've tried multiple medications before and there's one that works best for you, we would recommend restarting that in pregnancy if you are having depression in pregnancy. If it's the first time you've ever been depressed, you've never been depressed before, you've never tried medications before, typically people would start Zoloft or sertraline. That's because it has good safety data. It has low placental transfer, low levels in breastfeeding or low levels in breast milk with breastfeeding. So it is a good option. But what I don't want people to think is that that's the only medication you can take in pregnancy or it's the safest. So you have to, again, muscle through, even if it's not working well for you. Really, what the data supports is we want to use the medication that works best for you.
Yeah.
And across the board, we have, really sufficient safety data for almost all of the antidepressants at this point. And so really kind of doing personalized care, working with someone who knows you and who can help you sort of have, a personalized recommendation for your situation, given the symptoms that you're experiencing.
Amazing. Thank you. Okay, tell us where people can hear you, because I'm sure they wanted to know or reach out to you. Where can people get in contact?
Oh, yeah, of course. So people can look me up. I have a website. I have a private practice in Santa Monica. I also am the director of the UCLA Women's Life Center. So if people want one-time consultations or to be seen for pre-pregnancy consultations, they're welcome to reach out there. I also have an Instagram where I post typically just clips of lectures I've given in the past. That's Dr. Katie MD. Yeah, and hopefully we can connect.
Thank you. I'm so grateful again. This has been so timely and I think so important for people to hear. So I'm so grateful.
Of course, thanks for having me. Thanks for doing this.